Welcome to our channel, where we break down critical health issues with clarity, compassion, and credibility. Today, we're tackling a highly important topic that often goes under-recognized but can have serious consequences for both mother and baby: liver disease in pregnancy. Did you know that the liver undergoes significant physiological changes during pregnancy? And in some cases, these changes can reveal or even trigger liver dysfunction, from mild enzyme elevations to life-threatening conditions like acute fatty liver or HELLP syndrome. Liver diseases in pregnancy are not just rare curiosities, they're urgent medical realities that demand awareness, early detection, and expert care. But here's the real shocker: many of the symptoms of liver disease, like fatigue, nausea, itching, or swelling, can mimic normal pregnancy complaints. That makes it incredibly easy to miss, delay, or mismanage. And that's exactly why we're here today. In this deep dive video, we'll uncover the full landscape of liver-related conditions that can occur during pregnancy. We'll explore their causes, signs, diagnostic clues, management strategies, and what every expecting mother and family member needs to know to safeguard maternal and fetal health. Stay with us until the end for essential tips that could make all the difference during a high-risk pregnancy. Because understanding liver disease in pregnancy isn't just about knowledge, it's about saving lives. So, let's dive in. The liver is one of the most vital organs in the human body, responsible for over 500 essential functions. These include detoxification, hormone metabolism, bile production, nutrient storage, and synthesis of crucial proteins, including clotting factors. During pregnancy, the liver adapts to new physiological demands, such as increased blood volume, changes in estrogen and progesterone levels, and shifts in metabolism. Normally, pregnancy causes slight changes in liver function tests. For instance, albumin levels drop due to plasma dilution, and alkaline phosphatase may rise as the placenta produces this enzyme. However, these are considered physiological changes and not signs of liver disease. Despite these normal adaptations, certain liver conditions are unique to pregnancy, while others may be pre-existing or coincidentally arise during gestation. It's crucial to distinguish between them because their causes, treatments, and risks vary greatly. Liver dysfunction in pregnancy is generally categorized into three types: liver diseases unique to pregnancy, such as Intrahepatic Cholestasis of Pregnancy, ICP, HELLP Syndrome, and acute fatty liver of pregnancy, AFLP. Liver diseases coinciding with pregnancy, such as viral hepatitis or gallstone disease. Pre-existing liver diseases that are present before pregnancy and may flare up during gestation, such as autoimmune hepatitis or cirrhosis. Understanding these categories helps guide appropriate treatment, risk stratification, and delivery planning. Let's now explore these conditions in depth, starting with the ones that are exclusive to pregnancy. Intrahepatic Cholestasis of Pregnancy, ICP, also known as obstetric cholestasis, is the most common liver disorder that occurs exclusively during pregnancy. It typically arises in the second or third trimester and is characterized by impaired bile flow. Bile acids accumulate in the blood and cause a range of symptoms. The hallmark symptom of ICP is intense itching, especially on the palms and soles, without an accompanying rash. Other symptoms may include dark urine, pale stools, fatigue, and mild jaundice. Although the mother usually recovers completely after delivery, the condition poses serious risks to the fetus, including preterm labor, fetal distress, and even stillbirth. The exact cause of ICP isn't fully understood, but it's thought to involve a combination of hormonal, genetic, and environmental factors. Estrogen and progesterone levels rise during pregnancy and may interfere with bile transport. Genetic mutations in bile acid transport proteins, like ABCB4, have also been implicated. Diagnosis involves checking serum bile acid levels, liver function tests, and ruling out other causes of hepatic dysfunction. Elevated bile acids above 10 mol/L, particularly above 40, confirm the diagnosis and determine the severity. Management centers on reducing bile acid levels and preventing fetal complications. Ursodeoxycholic acid, UDCA, is the most effective treatment. It improves bile flow, reduces symptoms, and may lower fetal risk. Regular monitoring of liver enzymes and bile acids is essential. Delivery is often induced around 37 weeks to prevent stillbirth. With timely diagnosis and management, the prognosis for the mother is excellent, although there's a high chance of recurrence in future pregnancies. HELLP syndrome stands for hemolysis, elevated liver enzymes, and low platelet count. It's considered a severe form of preeclampsia and occurs in about 0.5 to 0.9% of all pregnancies, most cases present in the third trimester, but HELLP can develop as early as 20 weeks or even postpartum. The condition is life-threatening and can progress rapidly. The symptoms of HELLP syndrome are often nonspecific and include fatigue, right upper quadrant or epigastric pain, nausea, vomiting, and sometimes blurred vision or swelling. Many women may not have elevated blood pressure or proteinuria, which makes early recognition more challenging. Hemolysis refers to the destruction of red blood cells. This, combined with liver damage, elevated AST and ALT, and a drop in platelets, thrombocytopenia, creates a toxic environment that can lead to complications like liver rupture, renal failure, pulmonary edema, and disseminated intravascular coagulation, DIC. The cause of HELLP syndrome is not fully understood, but it's believed to involve abnormal placentation, immune dysfunction, and vascular endothelial injury. The key is early detection. Diagnosis is based on lab findings. Hemolysis is indicated by elevated LDH, low haptoglobin, and peripheral smear changes. Elevated liver enzymes, AST70U/L. Platelet count below 100,000/L. Management of HELLP syndrome requires immediate hospitalization. If the pregnancy is beyond 34 weeks or maternal/fetal deterioration occurs, prompt delivery is the only definitive treatment. Corticosteroids like dexamethasone may be used to mature fetal lungs and stabilize platelet counts temporarily. Blood pressure control, magnesium sulfate for seizure prevention, and supportive care in an ICU setting are often necessary. With early intervention, maternal survival rates are high, but complications can still occur, including liver hematomas and long-term cardiovascular risk. Acute fatty liver of pregnancy is a rare but catastrophic condition that typically occurs in the third trimester. It's caused by mitochondrial dysfunction and the oxidation of fatty acids, often due to a genetic deficiency in the fetus, LCHAD mutation. AFLP is marked by rapid liver failure, coagulopathy, encephalopathy, renal dysfunction, and hypoglycemia. It's more common in first pregnancies and with male fetuses. The condition has a maternal mortality rate of up to 20% if untreated. Early symptoms may include malaise, nausea, vomiting, abdominal pain, and jaundice. As the disease progresses, signs of liver failure, confusion, coma, bleeding become apparent. Diagnosis is primarily clinical, supported by lab tests showing elevated liver enzymes, bilirubin, prolonged PT, low glucose, and possibly elevated ammonia. Imaging may reveal a hypodense liver, but liver biopsy is rarely performed due to bleeding risk. The Swansea criteria, a set of 14 clinical and lab findings, are often used to aid diagnosis, requiring 6 or more features for high suspicion. Immediate delivery is essential, regardless of gestational age. This alone can stop disease progression. Supportive care in an intensive care unit, managing fluids, correcting coagulopathy, and treating hypoglycemia is critical. Maternal prognosis has improved dramatically with better ICU care and early delivery. However, fetal outcomes remain guarded due to preterm birth and intrauterine distress. Genetic counseling is recommended in future pregnancies due to the hereditary nature of the condition. Pregnancy can be complicated by chronic liver diseases that predate conception. Women with conditions like autoimmune hepatitis, chronic hepatitis B or C, cirrhosis, or primary biliary cholangitis, PBC, may face significant risks. Autoimmune hepatitis, AIH, a chronic inflammatory liver disease, can flare during pregnancy or postpartum. Close monitoring of liver enzymes and immunosuppressive therapy, like azathioprine or prednisone, is often required. With careful management, most women can carry to term safely. Chronic hepatitis B and C pose a risk of vertical transmission to the baby. Antiviral therapy with tenofovir during the third trimester and immediate postnatal vaccination of the newborn can drastically reduce this risk. Cirrhosis significantly increases the risk of variceal bleeding, miscarriage, preterm labor, and hepatic decompensation. Women with portal hypertension may require band ligation of varices before pregnancy or close endoscopic monitoring during gestation. Advanced cirrhosis, Child-Pugh B or C, often contraindicates pregnancy. For women with PBC or primary sclerosing cholangitis, PSC, liver function must be closely watched. Fat-soluble vitamin deficiencies may require supplementation, and UDCA remains the cornerstone of treatment. Planning for pregnancy in women with pre-existing liver disease should involve a multidisciplinary team, hepatologist, obstetrician, and anesthesiologist, to minimize complications. Sometimes, women develop liver diseases during pregnancy that aren't directly related to gestation. The most common of these include viral hepatitis, gallstones, and drug-induced liver injury, DILI. Viral hepatitis A, B, E, and C can present during pregnancy. Hepatitis E is particularly dangerous, with a mortality rate of 15 to 25% in pregnant women. It can lead to fulminant liver failure, especially in the third trimester. There is no specific treatment, so prevention via hygiene is essential. Hepatitis B is of special concern due to its chronic nature and risk of perinatal transmission. Mothers with high viral loads should receive antivirals in the third trimester, and all infants should receive hepatitis B immunoglobulin and vaccine at birth. Gallstones can be triggered by pregnancy-induced changes in bile composition and decreased gallbladder motility. Gallstones may cause biliary colic or even acute cholecystitis. Most cases are managed conservatively, but surgery may be needed if complications arise. Drug-induced liver injury can result from common medications, including herbal supplements, antibiotics, and anticonvulsants. This highlights the importance of avoiding over-the-counter or unapproved treatments during pregnancy. Diagnosing liver disease in pregnancy requires a careful balance. Many routine symptoms, like fatigue, nausea, or itching, can be easily dismissed. Thus, early and thoughtful use of diagnostics is critical. Liver function tests, including AST, ALT, bilirubin, and alkaline phosphatase, are the first step. Serum bile acids are particularly important in diagnosing ICP. Coagulation panels, complete blood counts, and renal panels help assess disease severity. Ultrasound is the imaging modality of choice due to safety and reliability. It can assess liver size, rule out bile duct obstruction, and evaluate for gallstones. In severe cases, MRI without contrast may be used safely in pregnancy. Regular fetal monitoring is also necessary, especially in conditions like ICP and HELLP. This may include non-stress tests, biophysical profiles, and Doppler studies to assess placental blood flow. Although some liver diseases in pregnancy are unpreventable, many risks can be mitigated through prenatal care, early screening, and lifestyle management. Women with known liver conditions should ideally be stabilized before conception. Regular follow-up with a hepatologist and high-risk obstetrician is crucial. For conditions like ICP or AFLP, awareness of family history, avoidance of hepatotoxic medications, and regular bile acid monitoring can aid early detection. Postpartum follow-up is also essential. Some women may experience recurrence in future pregnancies, while others may be diagnosed with chronic liver disease for the first time. Breastfeeding is generally safe in most liver conditions, but medication safety should always be verified. Liver disease in pregnancy is a complex and often unpredictable challenge, but with knowledge, vigilance, and the right care team, mothers and babies can thrive. Today we explored how conditions like ICP, HELLP, and AFLP arise, why they matter, and what can be done to ensure safe outcomes. We also discussed how chronic liver conditions and infections interact with pregnancy, highlighting the need for preconception planning and ongoing care. If you or someone you know is pregnant or planning to be and has liver-related symptoms, don't ignore them. Early testing, proper monitoring, and expert guidance can make all the difference. Remember, every pregnancy is unique, and liver disease doesn't have to mean danger. It just means we have to be smarter, earlier, and more proactive in our approach. If you found this video informative, please like, share, and subscribe for more medically backed content. And don't forget to leave your questions in the comments. We're here to help guide you through every step of your health journey. Thank you for watching, and until next time, stay healthy, stay informed,